what we wanted to give a flavor of in this last session was what's happening beyond our horizons of the Greater Mekong sub-region. And of course, you may or may not have realized that because of the artemisinin resistance emergence in the last few years, the GMS has been a pioneer of genomic surveillance, genetic surveillance, and we have done a lot of things that nobody else needed in the rest of the world. But now the tables have turned. There's been an emergence of artemisinin resistance in East Africa, and also transmission is getting lower in a lot of areas of Africa. So essentially, the scenarios are now starting to look similar. So what we wanted to hear about is some of the stuff that is going on in that continent, and perhaps again we can learn some things from that as well. So for the first talk here, I got Alfredo Mayor. He's a research professor at IS Global in Barcelona, and he does a lot of his work in Mozambique in the endemic area there. He has a strong interest in maternal and newborn health, and he's been actually conducting quite a lot of work on genetic surveillance. So we're looking forward to hearing.
Thank you very much for the introduction and for the invitation to share the work we are doing in Mozambique. So I'm going to talk specifically about sampling strategies. So how do we collect samples in a context such as Mozambique, where the burden of malaria is very high? So this is different, for example, to this region where there are very few cases, less cases than Mozambique. So first of all, a presentation of the country, Mozambique. So here you can see Mozambique is the 4th country in terms of number of cases. We have around 10 million cases per year. You can see the map there of Mozambique. There are 3 regions, administrative regions, the north, the center, and the south, 11 provinces, 154 districts, and around 1,600 health facilities in the country. And you can see the prevalence. This is obtained through household surveys. So the prevalence of malaria in children found in the community. And you can see that the burden of malaria, the prevalence goes from very high in the north, Cabo Delgado, 50, almost 60%. And then as you go to the south, the prevalence goes very down, as it happens here in the Maputo province. The capital is here, Maputo, where the prevalence is around 1%. So the National Malaria Control Program is aiming to eliminate malaria in the south while reduce the burden of malaria in the north. So GenMoz project, genomics, malaria genomics in Mozambique, aims to address 4 use cases. Antimalarial resistance, diagnostic resistance, importation versus local transmission in the south. We also are exploring the use of genetic diversity as a marker of the intensity of transmission and to assess the effectiveness of the interventions. And we are also studying malaria in pregnancy. As a pregnant woman at first antenatal visit can be a easy access group that could act as a sentinel population. So we are also studying the potential of this group to provide information on the burden of malaria in the country and also genetic indicators. So this project started in May 2021. At that moment, there were no sequencing capacities for malaria in the country of Mozambique. So here you can see a few milestones that we achieved until now. We started the field activities in January 2022. We got the sequencer, a MySec, in the Banjisa Health Research Center. Here you can see Simon Buene, very happy after many efforts to get the sequencer, many procurement issues, customs regulations. So it took almost 1 year to get the sequencer. After training of the team here in Mozambique, we were able to produce the first set of NGS results in June 2022. And since then, we have been providing this information to the National Malaria Control Program, who is through a dashboard that we have been able to develop. The NMCP has a dashboard which is integrating all the sources of information, including the genetic data. So many thanks to Gates Foundation to make this possible, and especially to Esther for her enthusiasm and support. So one of the first things we had to face since the beginning is to decide which samples, how we are going to collect the samples, taking into account that we have high burden, malaria, many cases, how we can define a set of samples that will be analyzed. So our first approach was a convenience sampling. So when we started this project, we were collaborating with a team, Malaria Consortium, who was conducting some activities in health facilities in the country. So we decided to partner with them and to use their work, their contacts in the health facilities to collect the samples. Here you can see the different dots where different health facilities distributed around the country that where we integrated the sample collection. So this allowed us to provide a first set of results or data. Here you can see almost negligible deletions in HR2 and 3, no mutations associated with partial resistance in KEL13, high prevalence of quintuple mutants in the HFR DHPS, but low mutations in 581. And we were able to quantify the importation of malaria cases in the south with a run of 25% of the cases being imported from Inyan Valley, this province. So, well, I want to thank many people working in generating all this data, especially Clemente, who has been organizing, coordinating the sampling activities, Simon, who has been in charge of the laboratory, Gloria of the ANC activities, and Arlindo on the then sampling in the south. However, this approach has limitations. We know we have been using a convenience sampling, which is a non-probabilistic approach. This can introduce biases and may not capture the heterogeneity of malaria genetic composition in the country. So we decided to improve this approach towards a more probabilistic approach. To do this, we established a working group with different researchers working in this area, including Deusis and Goma from Tanzania, Robert Verity from Imperial College, and Josh Proctor from ITM. So we started to think how we can establish a probabilistic approach that can provide representative data. So I think the two key aspects for this is to decide which is the sampling approach, where and how we sample, and the sample size, how many samples we collect. This is important, the sampling approach, to have a representative information of the country, and the sample size because we don't want to collect more or less than what is needed. So we don't want to collect more because this has a cost. So we want a sustainable approach. And we don't want to collect less because then we will not be able to be conclusive on the results. So both the sampling approach and the sample size will be determined by the use case and the goal. So we decided to focus on the most relevant use cases, which is antimalarial and diagnostic resistance. And here we can face the question, I would say, in three ways. No? Three different questions, but very, very related. So first of all, we may want to detect emerging variants of concerns. So mutations that are still not present. We want to see if they appear in the country, such is the case of K13 in Mozambique. We may want to measure the prevalence of variants of concern that are already existing, such as DHFR, DHPS mutations. Or we may want to compare the prevalence to a given threshold, such is the case of HRP2 deletions, given the recommendation of the WHO to change the RDT if the prevalence of mutations is above, of deletions is above 5%. So these are the three questions that we wanted to address and to define which could be the sample size and the sampling approach. In terms of sampling approach, well, the ideal would be to do a simple random sampling. I mean, to select randomly individuals in Mozambique, but this is not possible. So the other approach is through a cluster sampling, a multi-stage cluster sampling. So first of all, we select clusters, in this case, health facilities, randomly, and then we select individuals in those health facilities. This approach, to calculate sample size, to design this, we need to take into account the intra-cluster correlation coefficient. This means that the individuals in the same cluster are expected to be more related among them, in this case the parasites, than between clusters. So this introduces a factor that needs to be taken into account in the sample size calculations. Usually it increases the sample size required. So this is the new design, that the sampling scheme that we have designed for Mozambique, taking into account all these considerations. And this has been done in close collaboration, conversations with Rob Verity from the Imperial College of London. So we were analyzing different scenarios, taking into account the power of the conclusions that we can reach, and also feasibility, how much we can do. So we tested different situations and we end up with this one. So this means randomly selecting 40 clusters in the country, 40 health facilities, 4 clusters per province. So here you can see that the 11 provinces, we select 4 clusters for health facilities in each province, and 60 samples, 60 individuals per cluster. So let's see what we can get with this design. So for the first objective, which is to test against a threshold, in this case, this 5% of HRP2 deletions. If we analyze per province, each of these 11 provinces, we get a confidence of 65%, which is not so good, taking into account intercluster correlation of 0.05. However, if we test by region, so remember we have 3 regions, north, center, and south, we reach a 90% and 80%, depending on the coefficient of correlation, which is acceptable. If we want to test the prevalence of a marker that's already existent, such as the DHPS mutations, and assuming a 90% of prevalence, with this design, we can achieve a 5% margin of error per province, or 7.5, depending on the coefficient of correlation. And to test if there is or not a given mutation, such is the case of mutations in KL13 or the HPS 581, assuming that these mutations are at 1%, we achieve a power of 45 per cluster per health facility, which is very low, and 85% per province with this coefficient of correlation, or a 70% per province. So overall, this design allow us to detect good confidence deletions of HRP2 below 5% with a power above 80% at regional level. It allows us to detect the prevalence of DHPS mutations with at province level, and the presence or not of KL13 at also a province level with this level of confidence. In the case of southern Mozambique, which is Maputo province, low transmission, which is targeted for elimination by the National Malaria Control Program, we don't have this issue of selecting. We are conducting a dense sampling, so we are collecting all the clinical cases, with more or less, to give you an idea, is around 600 per province. There are 7 provinces here in Maputo province. Sorry, districts in Maputo province. Yeah, so basically this is what we have learned in GenMoz project. We have moved from this convenient sampling, which was good enough to generate preliminary evidence, to this probabilistic approach, multi-cluster sampling, which we have to conduct in this new phase of surveillance in Mozambique. Everything that I have explained here has been recently published through this group of this team that were discussing about these sampling issues. And yeah, I want to thank the team in Mozambique, the team in Barcelona, in UCSF, IDM, Malaria Consortium, and the funders, the Gates Foundation. Thank you very much.
Thanks, Alfredo. That's a very interesting sort of consideration for sampling. Any questions for Alfredo?
There's a question. You also sampling to detect the SRP2 deletion gene. So in Mozambique, you when make diagnosis for PF, where you use slide reading or RDT.
We are using mainly RDTs in Mozambique.
Yeah.
In there, some health facilities, it's possible to do microscopy, but in remote health facilities, it's not possible. So RDTs.
Yeah. And where somewhere you also have microscopy?
Yeah, somewhere we have microscopy.
So what is the percentage of RDT negative and uricide positive? Yeah, I mean, do you find any percent?
Discrepancies in the test suggestive of deletions?
Yeah.
Very, very few. So the recent study that we included like 2,000, 2,500, we observed like 20 discrepancies.
Oh, okay.
And among those, we demonstrated deletions in only 4. So it's very low at this moment.
Yeah, actually, we also did the similar study in Vietnam. And first we see about 5-10% difference compare RDT and slide. But actually, when we analyze, we find 0 gene deletion. So maybe because of the quality of the data and also because of the sensitivity and also during the start, maybe it's make the quality going down and finally we find zero. Yeah. Okay, thank you.
Good news, huh?
Yes, Steph.
So I was just going to make a comment following on from that publication. There's also an online resource available that Bob Verity, who's one of the co-authors, has developed, and that's if you're designing HRP23 deletion surveillance studies, it can help you to calculate the optimal sample size and sampling strategy. And I believe the WHO protocol is about to be updated. He's also working on one for drug resistance, but that's still under development. And once that's available, I'm sure it'll be discussed.
Yeah, I saw Bob's presentation. The tools he's putting online are very, very useful, actually.
And he's a very friendly guy. So he's always delighted to hear from people if you want any advice, formal or informal. I think he's a very responsive person.
Indeed. Thank you. Ian.
Just a minor add-in information that I thought, learning from what we have done in our group, that sometimes the inconsistent between the RDT positive and the slide positive, we may not found the deletion in those samples, but deeper analysis, this may be some different in the motif of amino acids related to the HRP2 and 3. Then please move forward with this.
So the discrepancy between tests can be due to different reasons such as quality, parasite density, and so on. Yeah. So
But
Yes, but if you think it's a variant, that's worth investigating further. That's
because there are variant in the amino acid motif depends on within the HRP2 and 3 gene region, and also upstream, downstream.
okay, not only deletions, you mean also changes in the amino acid composition?
The flanking gene.
Okay. Interesting. Yeah.
yeah, that would worry people more.
Yeah, that would be worrying because now, I mean, the WHO recommendation and what most laboratories are doing is testing if there is a deletion, not really sequencing. But yeah, interesting.
Yeah, again, that's an area where nanopore, for instance, would be helpful. Because again, you can get a big stretch of sequencing. Yeah. Richard.
Just a question for Alfredo. So some countries are facing increases in cases for whatever reason, and it can come to the point where they can't collect samples from everybody. So do you have any suggestions for how they could maintain genomic surveillance? Or what should their sampling strategy be?
Well, I think the simplest one to answer the specific question that they want to address. So I think if it is resistance, molecular markers of resistance, I would say that this sampling scheme that we are proposing for Mozambique, I would say is one of the most simple ones. It will, of course, you need to take into account how big it is the country and how big to be the health facilities. But this approach would lead to around 2,400 samples, which is not a super big amount. And this would allow to do one per year or 1 years. So I would recommend this kind of approach.